female reproductive systems. This is an overview of the present lecture. We'll cover the male reproductive system in terms of describing accessory organs, the semen, the testis, the hormones involved in male reproductive system, aging as it pertains to the male reproductive systems, and any disorders associated to male reproductive system. For female reproductive system, we'll look into accessory organs, we'll describe the ovaries, the reproductive cycle, menopause, and disorders of female reproductive system. We'll discuss, in addition to that, birth control and infertility issues as they pertain to both male and female. Please take a minute and stop this lecture in order to review the learning objectives. There are a few types of reproduction, and when we are looking at the simple forms of life, those that are made out of one cell, the one-celled organisms, usually they do not have a partner in order to reproduce. They simply divide themselves, and this type of reproduction is called an asexual, or non-sexual reproduction. Most animals, definitely primates, and among them the humans, they have a reproduction that is called sexual, meaning that there is a need for two different kinds of individuals. One is a male and one is a female, that each will bring in specialized cells that are designed and produced specifically for perpetuation of the species. Those specialized sex cells are called gametes and or germ cells. And in case of the male, they are called spermatozoa or spermatozoon, or simply sperm cells. And in the female, they are called ova or ovum or eggs. Those gametes are produced through a special type of division that is called a meiosis. And in this process, the cell is splitting in half the number of chromosomes. And as a result of that, each daughter cell, each gamete cell, will have only half of the genetic luggage. Instead of having 46 chromosomes, as normal somatic cells will have, a gamete will contain only 23 chromosomes. When we look at the male and female reproductive systems, we'll look into two groups of organ. We have what is called a primary and accessory organs. We have the primary organs being the gonads, those parts of the reproductive system that are the sex glands, that they are producing the gametes, and in addition to that, will manufacture the hormones that are supposed to maintain and support the reproduction process. The male gonad is the testis, while the female gonad is the ovary. In addition to those two very specific and specialized organs, the reproductive system, both female and male, will have accessory organs that consist in a series of ducts and structures that will transport the gamete, as well as they will have some various exocrine glands that will support the reproduction process. We'll describe now the male reproductive system, and we'll start by saying that the main function of the male reproductive system is to produce the spermatozoa, and the spermatozoa will be transported and eventually delivered to the female in a fluid that is called the sperm. We'll describe now the accessory organs, and we'll start by describing the spermatozoa pathways. Definitely, the process starts at the level of the testis, and we'll discuss in detail the structure and the function of the testis. But let's put it aside for a second. The testis will deliver the spermatozoa into a coiled tube, and that coiled tube is called the epididymis, about 6 meters long, about 20 feet long, located on the posterior surface of the testis. During the passage through the epididymis, the sperm cells will become more and more mature and will gain what is called mobility. They will be able to move on their own and while they will be delivered outside the epididymis um, in the upward part of it through a structure that is called ductus deferens, the spermatozoa are actually at that point able to swim on their own. Ductus deferens, or the vas deferens, is a tube that loops over the pubic bone. You can see it, you can follow it on the picture. There are some blue arrows that you can follow. Will loop over the pubic bone and will curve behind the urinary bladder. And it widens it um, just where it's supposed to join with the seminal vesicles. It widens to form a dilation. All the dilations in our bodies are called ampulas. So it will form an ampulla and will join the seminal vesicles, um, and will form, once they join the seminal vesicles, they form the ejaculatory duct. We have a right and left ejaculatory duct that will travel through the body of the prostate gland now. And once they are gaining the fluid from the prostate also, they will empty inside the urethra. The name semen means seeds, and is a mixture of sperm cells or spermatozoa and various secretions that are produced by the other glands, accessory glands, that is expelled from the body, and will the main function of the semen is to transfer and transport the spermatozoa from the male partner to the female partner. It is a sticky fluid. It has a milky appearance, and the pH is um, in the alkaline range between 7.2 and 7.8. The glands that are accessory organs for the reproductive system are producing fluids that their functions are to nourish the spermatozoa, to transport them. Um, Another function is to try and neutralize the acidity of the male urethra and the female vaginal tract. Um, they will lubricate the reproductive tract during the sexual intercourse. And last but not least, they have an important function in preventing infections because they will contain some antibacterial enzymes and antibodies. Now, what are those accessory organs, and they are considered glands that they are contributing in producing the semen? We will start first with the with the seminal vesicles. There you can see them in this. If you look into they are um, colored in a purplish color, just behind the urinary bladder, kind of on top of it. And the seminal vesicles are can be described as a twisted muscular tube, and they have a lot of outpouching. They are about 3 inch long, attached to the posterior wall of the urinary bladder, and they will secrete a thick yellow alkaline secretion that has a lot of sugars in it, and those are essential for the transport and nourishment of the spermatozoa. The seminal fluid makes up for the biggest part of the semen's volume. And it makes sense to be that because if you look into the pathway of the spermatozoa, you see that the first gland that the ductus deferens, the vas deferens, encounter in its way is the seminal vesicle. So it makes sense that most of the fluid will come from it because the sperms will need um, the transport medium. The next gland, it's in baby blue um, at the bottom, at the neck of the urinary bladder in your image. The prostate gland lies just inferior to the urinary bladder, and it surrounds the first part of the urethra. So the ducts from the prostate will carry the secretion into the urethra. Now, this secretion, the prostate secretion, is thin and alkaline and will neutralize the vaginal and also the urethral acidity and will enhance the spermatozoa motility. The prostate gland has also some muscular tissue that will aid and contract to aid in the expulsion of the semen from the body when needed. Now, moving downwards with the pathway of the sperm, you see another structure really low in the pelvis, close to the pelvic floor. that is called bulbourethral gland. We have two, men have two of those. They're also called Cooper glands, and they are pair pea-sized organs just in the pelvic floor inferior to the prostate gland. And they will secrete mucus that will lubricate the urethra and the tip of the penis during sexual stimulation. Other very small glands will secrete mucus into the urethra and as the urethra is passing through the penis. We are looking now at the urethra and the penis. So in male case, the urethra has a dual purpose, both for transporting the urine from the bladder outside and also to transport the semen from the ejaculatory ducts to the outside. Uh, Semen ejaculation is possible by erection, and erection represents the stiffening and enlargement of the penis through which the major portion of urethra actually extends through it. When we are looking at the structure of the penis, and you see in this image, you have a section of it. You can see that it's made out of spongy tissue that has many blood spaces. And those are most of the time relatively empty whenever the organ is flaccid, when it's not in erection. Once those spaces will fill with blood and will distend, the penis will become erect. This tissue can be subdivided. If you look into that, you can see three areas. Can be subdivided into three segments, and each of them are called a corpus or a body. And you can see that you have a single and ventrally located is the one on the bottom of the picture. And ventrally located corpus spongiosum that will contain the urethra inside. And on the other side, and on top of it, you have two largest bodies that are called corpus cavernosum or corpora cavernosa. At the distal end of the penis, the corpus spongiosum enlarges to form the glans penis. This usually is covered with a loose fold of skin, the prepuce, that is commonly called, popularly called the foreskin. This part can be removed in a procedure that is called circumcision. Circumcision is performed in male infants, can be done for religious or cultural reasons, and also now there is a more and more fashionable, and it's seen as a hygiene type of behavior, because there are studies that can show that by performing circumcision, we can lower the incidence of penile cancer in males. However, there are various opinions from a medical point of view regarding the value of circumcision, regarding the improved cleanliness or disease prevention. Ejaculation represents the forceful expulsion of semen through the urethra to the outside, and those reflexes are initiated by centers in the spinal cord that will stimulate the smooth muscle that will contract at the level of the prostate. And in addition to that, there will be a synchronous contraction of the skeletal muscle in the pelvic floor that will provide the force necessary for expulsion. Another thing that happens in the same time is that the involuntary sphincter at the base of the bladder will close and will prevent the release of urine at the same time, as well as preventing what is called retrograde ejaculation, the penetration of the semen inside the bladder instead of being exposed at the outside. Typically, every time that the male will ejaculate, there will be 2 to 5 milliliters of semen that will contain between 50 and 150 million sperm cells per milliliter. Out of all those millions of spermatozoa, only one, if any, will be able to eventually fertilize an ovum. The remainder of those cells can live in between a few hours up to a maximum of 5 to 7 days inside the female reproductive tract, with those cells that are carrying an X chromosome being a little bit bigger and living longer than those that are carrying an Y chromosome. The testes are a paired organ that are located outside of the body, and they are located in a sac that is called the scrotum, and they are suspended between the thighs of the male. The penis and the scrotum together will make up for what is called the external genitalia. At the level of the scrotum, beside the testis, inside this sac, we'll be able to find the epididymis and the proximal portion of the ductus deferens. The testis, as you can see in this image, there are some oval structures measuring 4 by 2.5 centimeters. During the embryonic life, the testis will start developing inside the abdominal cavity, pretty close to the level where the kidneys are. 1 or 2 months before the birth, each of the testes will normally descend, will move towards the inguinal canal, and through the inguinal canal, from the abdominal cavity, they will descend inside the scrotum. So normally at birth, the testes will be placed inside the scrotum. Because their development starts at the level of the abdominal cavity, very close to the kidneys, just below them, their vascular supply, the testicular arteries and veins, will have their origin and end correspondingly at the level of the abdominal cavity. They just travel and they will increase the length of those arteries and veins. The testis is suspended by what is called the spermatic cord that will extend and will pass through the inguinal canal from the abdominal cavity to the outside. The cord will contain the blood vessels, lymphatic vessels, nerves, and ductus deferens. In order to be not highly functional, but normally functional, the gland, the testis, needs to be completely descended in the scrotum at birth. The production of spermatozoa is performed normally at lower temperature than the core temperature of our body. That's why the testicles need to be on the outside of the abdominal cavity and to have their temperature is a several degree lower than that of the inside of our body. Let's look at their internal structure. Inside the testicles, there are some cells that are highly specialized, and they consist of tiny coiled seminiferous tubules. Inside those tubules, there will be primitive cells that can divide, and can develop into spermatozoa. The spermatozoa will be supported by neighboring cells that are called sustentacular cells or Sertoli cells. Those cells will provide nourishment and protection to those newly developed gametes. The spermatozoa, once produced, will, and you can see in the bottom image in the middle, you can see how they go through different stages, and when they are close to the lumen, to the inside of the tube, they are almost looking like fully formed spermatozoa. Once produced, they will pass into the epididymis, and in the epididymis, they'll be stored and will go through what is called the final maturation. They will become the final cells. There are some other cells that are called specialized interstitial cells that are also present in the structure of the testis, and they are producing the male sex steroid hormones called testosterone. And they are also located in between the seminiferous tubules. The former name for those cells were the Levy cells. We'll discuss now the structure of the spermatozoa. They are tiny individual cells. They are so small that about 200 millions can be contained in about 5 milliliters. Sperm cells start to be manufactured at puberty under the control of the hormonal sexual hormones that start to be produced at puberty. This cell, the spermatozoon, is a very specialized, highly specialized cell with a very well-defined function. Because of that, the structure will adapt to the function. The spermatozoon has an oval head, and most of the head is actually the nucleus that will contain the chromosomes. There is not a lot of space around this area because they need to be very compact and very small, and they need to deliver the chromosomes. On top of it, um, the, um, the the head has a tiny cover. It looks like a cap that is called an acrosome, and this cap, this acrosome, contains enzymes that will help the sperm cell to penetrate the ovum. On the lower part, we'll have the tail that is a flagellum that will help propelling the sperm through the female reproductive tract towards the ovum. In the middle part, we have a mid piece that connects the tail to the head, and that will contain a huge amount of mitochondria that provide all the energy needed for the movement. Where are the enzymes that help the sperm cell penetrate the ovum located? A. Acrosome. B. Head. C. Midpiece. Or D. Flagellum. The enzymes that help the sperm cell penetrate the ovum are located at the level of the acrosome. Discuss now about the hormonal control of the male reproduction. So, as said before, the activities of the testis will be under the control of the sexual hormones. There are two hormones that will be produced by the anterior pituitary gland, um, and those will influence the production of the testicular hormones themselves. Um, those protein hormones are named for their activity in the female reproduction that we'll describe a little bit later, but they are actually chemically identical in male and will have an almost similar type of action on the male reproductive system. They are called gonadotropins because they are stimulating the gonads, and they are follicle stimulating hormone, or FSH, that in male will stimulate the sustentacular cells to produce growth factors to promote formation of spermatozoa. In other words, the FSH will promote the maturation, the development of the sperm, and luteinizing hormone that will stimulate the interstitial cells between the seminiferous tubules to produce testosterone that is needed and will support the development of sperm cells. So FSH is involved in the development of the cells themselves, while the LH is involved in the production of the hormones, the testicular hormones. Somewhere at puberty, the hypothalamus will start secreting the gonadotropin releasing hormone that will trigger and will start the production of the FSH and LH at the level of pituitary gland. The concentration of testosterone is relatively constant throughout the entire life since the puberty starts, and is regulated through a negative feedback mechanism. Whenever the blood level of testosterone will increase, the hypothalamus will secrete less. As a result of that, the pituitary gland will secrete less, and the testicles will be stimulated to produce less testosterone. We'll look now at the testosterone hormone itself. And so it's produced at the level of the interstitial cells, and it will be released in the bloodstream. Again, it's a hormone. It's part of the endocrine system. And its main functions are related to the development and maintenance of male reproductive accessory organs to support the reproduction process. They will stimulate the development of spermatozoa and also the development of secondary sex characteristics that are not related directly to reproduction, however, will differentiate between males and females. In males, those traits will include broader shoulders, narrower hips, greater percentage of muscle tissue, more body hair in completely different areas than the areas where the body hair will be found in females, and also a deeper voice. There are some effects of aging on male reproduction as well. There is a gradual decrease in the production of testosterone, as well as the spermatozoa, that starts usually around age 40 and continue throughout life. Along with that, the sperm motility and quality will decline somewhere midlife, However, many men will stay fertile until their 90s. The secretions from the prostate and seminal vesicles will also decrease in amount and will become less viscous. Um, there is a, an increased chance to have a diminished erectile function that can happen at any age, but its prevalence will increase with aging. Erectile dysfunction is defined as an inability to either attain or maintain an erection adequate to engage in intercourse. In addition to that, with aging, there is an enlargement of the prostate that is called the benign prostatic hyperplasia, that is a benign condition, non-malignant. Nearly all men by the age of 80 will have a certain degree of enlargement of the prostate. The enlargement of prostate can be associated with pressure on urethra and may interfere with urination, and in some extreme cases, they may even cause urinary obstruction. That will increase, obviously, the susceptibility to infection. BPH can be treated by medication that may help to prevent the further development of the hypertrophy, or may sometimes even help shrinking the prostate. And when that is not enough, there are surgical procedures that can treat the hypertrophy. We'll discuss now disorders of the male reproductive system, and we'll look first into the structural issues. We'll discuss later the infections and also the tumor. Part of the disorders of the male reproductive system is also the reduced men fertility or infertility, and we'll discuss that together with the female one at the end of this lecture. Let's look at the structural disorders. The first condition that I'll describe is called cryptorchidism, and this is a failure of the testis to descend to be present in the scrotum of birth. It's called crypto, means hidden. So the testicle can be anywhere on the pathway from the abdominal cavity through the inguinal canal to the entry into the scrotum. This condition needs to be treated as soon as possible because the testicle that is exposed for a long time to high temperature, to the increased temperature that are the core body temperature, may lead to infertility. In addition to that, an undescended testis may be subject to tumor formation. Most of the testes that are so-called undescended at birth will descend by 1 year of age. Whenever that doesn't happen, there is a need for a surgical correction. Another condition is called the testicle torsion, and you can see it on the top of your image. And it represents a rotation within the scrotum. Then, as a result of that, there is a twisting of the spermatic cord, and the twisting will put pressure on the artery and the veins that are supplying the testis, and as a result of that, the blood supply will be compromised. In normal developed testicles, they will be firmly anchored at the base of the scrotum, and they will not be able to twist around the axis of the cord. Whenever this is lacking, a testicle torsion can happen. Usually, it's common in young individuals, will happen after a certain physical effort, and starts with an excruciating pain, swelling, and it's a high emergency because the testicle can go through necrosis, needs to be treated as soon as possible in a matter of hours. Inguinal hernia. Hernia represents a rupture or an opening, and refers to the and regardless where we are looking at it, a hernia is an abnormal protrusion of an organ or part of an organ through the wall, usually the abdominal wall, the wall of the cavity, which is normally contained. The inguinal hernia occurs in the inguinal region and is a result of congenital weakness in the abdominal wall, where usually in that area where the testicle descended from the abdominal cavity inside the scrotum. Usually a loop of bowel or some parts of the abdominal fat will protrude from the abdominal cavity through the inguinal canal inside the scrotum. Um, the condition is produced because due to excessive pressure in the abdominal cavity, and this can be seen in people that are lifting heavy objects, and people that are chronic coughers, or people that are having a habit of constipation with continuous straining in the bathroom that increases the pressure. The inguinal hernia can become an emergency whenever one of those um, parts of the organs that are sliding out can be obstructed and can go through necrosis if their vascular supply is compromised. Phimosis is another condition that is characterized by a tightness of the foreskin or the prepuce that cannot be drawn back. The phimosis can be fixed by circumcision when that part of the foreskin is removed. Inflammatory conditions will include both infections and autoimmune diseases. The most common infection, it will be with an intestinal bacteria, which is Escherichia coli, which is typical for our, is typical in the populating the large bowel. The bacteria is spreading from the anus to the urethra and will infect the urinary tract. And from there, because in the male is shared with the reproductive system, can spread also to the reproductive ducts. Other infections are transmitted as sexual contact. Very rare infection will be transmitted by blood or lymph. Most of the bacterial infections will be treated with antibiotics and rest. Depending on the area where the infection takes place, the infection can result in prostatitis, which is the inflammation of the prostate gland. It can be followed by an epididymitis, which is an inflammation of the epididymis, or orchitis, which is inflammation of the testis, the testicle itself. A very common form of orchitis is encountered in infections with mumps, and this infection is usually spreading through the bloodstream. Orchitis may result in infertility, and usually it's a condition that occurs in before puberty or during puberty in individuals that were not vaccinated for mumps. We'll look now into the sexual transmitted infections or diseases. They are also called venereal diseases, and they spread through sexual contact in both males and females. Most common infections will involve chlamydia and gonorrhea. In males, those two will manifest themselves by a discharge from the urethra that may or may not be accompanied by a burning sensation and pain, especially during urination. This infection may travel and may cause prostatitis and epididymitis. When is not treated, may continue to develop to an orchitis, and when it heals, it will leave scar tissue that will destroy the tubules and may lead to infertility. Another type of STD that is pretty common is the genital herpes. It's called by a virus. Will be characterized by fluid-filled vesicles or blisters that can be seen on and around the genitalia. This condition will never be cured. Once a patient contracted it, they will always have it and will have recurrent attacks or outbreaks. There is currently medication, both topical and systemic, that can be prescribed in order to reduce the number and severity of the outbreaks. Another condition will be the syphilis that is called by a germ that is called Treponema pallidum, which is a spirochete. This condition will start with a lesion at the level of the genital area that in most cases will be will not going to concern the patient because it's unpainful. It will be like an ulcer and a tiny wound. This genital ulcer will heal very quick, and from the primary stage, the syphilis will go into what is called the secondary stage. Um, this is a condition that can be easily treated with one dose of antibiotics, which is a simple one, it's penicillin. However, it needs to be identified in time and treated. Um, we can say that about 2 million men and women will be affected each year by one or more than one sexual transmitted diseases. And in order to prevent that, education takes the first place. Um, in many cases, when we are treating those patients, we need to ask them about their partners, and the partners need to be treated as well in order to prevent reinfection. Cancer, and we'll discuss here, we'll start by describing the prostate cancer, but we'll also talk about testicular cancer. Prostate cancer is the most common cancer in males, and it's common in men older than 50 years of age. In terms of additional risk factors, we can add age, race, and family history, as well as environmental agents. We can say that a high-fat diet may increase the risk for producing male hormones, and as a result of that, development in the future of prostatic cancer. It can be uh, discovered, it can be diagnosed while performing a rectal examination. In addition to that, the patient can go and have a blood test done to determine the prostate specific antigen, which will not gonna put a diagnosis of prostate cancer. However, it can be used in the evaluation of the treatment and evaluating if the patient is going through a recurrence or not. The course of treatment it will depend on the age of the patient and definitely the um, aggressiveness of the cancer. It may range from surveillance to radiation therapy, surgery, or hormone treatments. Um, on the other hand, we have the testicular cancer that, as opposed to the prostate cancer, will affect mainly young to middle-aged adults. And most of the testicular cancers will arise in the germ cells because those are the cells that have the high rate of division and development. Um, this type of tumor, as opposed to the prostate cancer, will metastasize through the lymphatic system and at a very early stage of development. The early detection is essential, and that's why it's important to educate the patients in terms of weekly testicular examination, and will need to have the regular physical checkup, including a testicular examination by a provider. What is testicular inflammation called? A. Phimosis, B. Epididymitis, C. Prostatitis, or D. Orchitis. Testicular inflammation is called orchitis. We'll move now and discuss the female reproductive system. Um, the gonads for the female are a paired organ that is called, they are called ovaries. They will produce the gametes as well as some of the um, female reproductive hormones will be secreted as this level. The remainder of the female reproductive tract will be made out of um, tubular and muscular organ that is made to hold and nourish a developing embryo, a variety of passageways, and also the external genital organs. We'll look now into the accessory organs first, and we'll discuss the ovary after, just like we did in the male reproductive system. The accessory organs of the female reproductive system are the uterus, the uterine tubes, vagina, and the vulva. The breasts are also considered to be accessory reproductive organs because of their role in child nourishment. We'll look now at the uterus. You can see that is a big, muscular, pear-shaped organ. In size, it's about 7.5 by 5 by 2.5 centimeters. Um, this organ is meant to hold the embryo and the fetus and ensure their development up to the point where the fetus is mature enough to be delivered. The uterus will be a little bit larger in those women that have already had children and will become smaller and smaller in postmenopausal women. The superior portion of the uterus is close to the upper surface of the urinary bladder, while the inferior portion will be completely contained in the pelvic floor, and it's situated between the bladder and actually bladder and urethra and the rectum or anal canal in the posterior part. The upper part, which is wider, is called the body or the corpus, while the lower part, which is narrow, is called the cervix and is connected through a neck to the body. Part of the cervix will be seen inside the vagina, will protrude inside the vagina. The top of the uterus is small and rounded and is called the fundus. On both sides of the uterus, there are some folds of the peritoneum that are called the broad ligaments, and their main function is to support the uterus. They extend from each side of the organ to the lateral body wall and will literally hold the uterus in place. The ovaries are also suspended from the broad ligament, and the uterine tubes will lie on the top of it within the upper part of this border. All the blood vessels that supply the ovaries and the uterus and some of them are big blood vessels, are found in the layers of the broad ligament. They are included in the broad ligament 2 layers. The main layer of the uterus is called the myometrium. It's highly specialized and it's very thick. Inside, the lining of the cavity is done by a specialized epithelium that is called endometrium. And this layer will undergo the monthly changing throughout the woman's reproductive years, getting to the stage where this layer is developed enough to be able to nourish a fertilized egg. If there is no fertilized egg and no pregnancy starts to develop each month, this layer will break down and will slough out. As a result of this type of degeneration of the endometrial tissue, there will be seen as a menstrual flow. Uterine tubes. They are called also the oviducts or the fallopian tubes. Those are structures that are tubular, very not having a very wide diameter. They are about a quarter of an inch in diameter. However, they are long. They are about 5-inch long, 12.5 centimeters, and they extend between the uterus and they come very close to the ovary. They are attached and they connect to the uterus. However, they do not connect. They just lay over and around the ovary. The ova, the egg will be released from the ovary inside the abdominal cavity, and the fringe-like, the finger-type small extensions from the tube openings will create currents. They are moving constantly and will create currents in the peritoneal fluid that will capture and sweep the ovum inside the uterine tube. So the ovum is a one cell, it's one round cell, and as opposed to the semen, that the ovum is not able to move by itself, and it's progressed through the uterine tube is due to the movements and the contractions of the uterine tube's muscles. It takes about 5 days for the ovum to reach the uterus from the ovary after it was released from there. The vagina is a muscular tube of approximately 3 inches long, and the cervix can be seen protruding into the vagina's superior portion. Around this protrusion of the cervix, there are a few circular recesses that they are called fornix. The deepest one is the posterior one, just behind the cervix. And behind it, there is a narrow passage between the uterus and the rectum that is named the rectouterine pouch. And you can see those in the lower image. There is a thin layer of tissue that, if you look at that, you can see that it's a thin layer of tissue that separates the posterior fornix from this region to the between the uterus and the rectum. So any type of abscesses or tumors in the peritoneal cavity can be sometimes detected and examined by vaginal examination. The lining of vagina is a mucous membrane that is made out of stratified squamous epithelium, and it will have folds that allows for the enlargement and contraction of this structure or rugae that will accommodate mainly the childbirth. In addition to being part of the birth canal, the vagina is the organ that receives the penis during the sexual intercourse. There is also a fold of a membrane that is called a hymen that may sometimes be found at or near the vaginal opening. Moving forward with the accessory organs of the female reproductive system, we'll discuss now the greater vestibular glands. And those are situated just superior and lateral to the vaginal opening, and they are mucus-producing glands, and they secrete their uh, they produce their secretion into an area near the vaginal opening that is called the vestibule. Vestibule means entrance. Just like the bulbourethral glands in males, they will provide lubrication during intercourse. There will be, in terms of pathology of this type of this structure, they can become infected, and in this case, usually the treatment is a surgical incision with or without antibiotic therapy. Vulva and the perineum is the rest of the accessory parts. The external female genitalia is called a vulva and will include two pairs of labia. We have labia majora and we have the smaller ones that are called minora. It also includes the clitoris, which is a small organ with great sensitivity that lies at the opening of the urethra and the vagina. The anterior part that is made out of a pad of fatty tissue over the pubic symphysis is called mons pubis. In females, we call the entire pelvic floor is a perineum. Now, there is a certain difference in between the obstetric perineum and the one that we describe um, in anatomy, and there are similarities and differences between the male and female. However, when we are looking into the obstetric perineum, those that are dealing with this type of patients will call perineum only the part that lays between the vaginal opening and the anus, only the posterior part of it. Ovaries and ova. Ovaries are small and kind of flat, roundish organs, measuring 4 by 2 by 1 centimeters. They start developing just like the testis under the just below the um, kidneys in an embryo, and they will start descending, but they will stop at the level of the pelvic cavity. They are held in place by ligaments. Um, they will have the ovarian ligaments and the broad ligaments that attach them both to the uterus and to the abdominal wall. The outside layer of the ovary is a single layered epithelium, and the ovas, the eggs, are produced just beneath this layer. During the development of the ova, an oocyte that is contained within a small cluster of cells called an ovarian follicle will start to develop, and the follicular cells that are protecting the cell will produce the ovarian hormones. There is a slight difference between the male and female reproductive system in terms of gametes. While the males are starting to produce their gametes at puberty, the females are actually born with all the gametes that they will ever produce. The ovaries of a newborn female will have more than 1 million immature follicles. However, out of those million follicles, only a few hundred will remain viable. A few 100,000 will remain viable um, at puberty. Uh, as puberty kicks in, a few of those follicles will begin to develop, and the oocytes will enlarge, forming and allowing by doing that the follicular cells to multiply. Starting at this point at puberty, during each month, uh, one developing follicle will complete the maturation process and release one ovum. The final stages of development and release are, we'll discuss them when we'll discuss the female reproductive cycle. What structures suspends the uterus and ovaries in the pelvic cavity? A. Uterine tubes. B. Broad ligaments. C. Fimbria. Or D. fornix. The structure suspending the uterus and ovaries in the pelvic cavities is the broad ligament. So we'll discuss now the female reproductive cycle. In female, just like in males, the reproductive function is under the control of the um, pituitary gland. And we'll start with the gonadotropins that are released from the anterior pituitary gland. Um, the gonadotropins in the pituitary gland are under the control of the gonadotropin releasing hormones that are released by the hypothalamus. However, for females, if for the males, the production and the levels of testosterone are constant since the uh, since the beginning of the puberty, in female this will have a certain cyclicity, um, and the cyclicity is due to regular patterns of increases and decreases in hormone levels. In order to be able to define and describe this cycle, we'll start with a sign of those changes that is very obvious. And this is the periodic vaginal bleeding or the menstruation. And because of that, the cycle is called the menstrual cycle. Typically and on an average, the length of the menstrual cycle may be situated between 22 and 45 days with, again, an average of 28 days. We start counting the days with the first day of menstrual flow um, because this is the obvious sign and that's how we can track all the events. Um, Now we'll define the ovulation as the release of a gamete from the ovary. Um, and that separates the reproductive cycle into two periods. We have the pre-ovulatory or follicular phase, and we have a second one that is called post-ovulatory or luteal phase. So it's important to remember the moment of ovulation will split the cycle into two parts, pre and post-ovulatory, follicular versus luteal. So as the follicle will grow and transform, it will produce various amounts of ovarian hormones. And you can follow the different stages of ovarian maturation um, along with the different levels. You have the graph underneath um, all the changes that happens at the level of the in changes in the levels of the hormones of the estrogen and progesterone, and the lower graph will show you the maturation, the development of the um, endometrium at the level of the uterus. So we'll look into each of those phases now. We'll look at the pre-ovulatory phase. Um, at the start of each cycle, several follicles that will contain an ovum will start the final stages of maturation. However, uh, only one will finalize it. And once the follicles are starting to mature, it will enlarge and fluid will accumulate in its central cavity. Just follow the stages in the second from the top where it says ovarian events. While it's growing, the follicle will start secreting increasing amounts of ovarian hormone called estrogen. Now you can look at the third from the top, and you can see how, along with the maturation and accumulation of fluids inside the follicle, there is an increase of the estrogen up to a point very close to the moment of ovulation, when that's the top of it. It's the maximum of the secretion of estrogen. Estrogen is needed in order to support it. It feeds back the maturation of the follicles. Most of the follicles that started all together will kind of die off and not finalizing the maturation, and only one will survive and will release an ovum during the ovulation. All those maturing follicles that do not release their ova will simply degenerate. The estrogen produced by the follicles will also travel through the blood to the uterus, and will start preparing the uterus and especially the endometrium for a possible pregnancy. And this preparation will be reflected into a thickening of the endometrium and an elongation of the glands that will produce the uterine secretion. It's kind of preparing a bed for the implantation of the pregnancy. The time between the menstruation and the ovulation is called the proliferative phase of the uterine development. So when we are looking, you can see on the lower line, you can see in pink it says menstruation, and you can see that the layer of the endometrium epithelium is almost zero. It's almost inexistent, but it starts to increase once the estrogen starts to increase, and it's called the proliferative phase. Also, during this cycle, the estrogen will have a negative feedback effect on the release, the gonadotropin release hormones, and also on the FSH and LH. However, the moment that the estrogen will reach the highest level, it will, contrarily from what you will maybe think about it, will stimulate the production of both gonadotropin releasing hormones and LH, and that is called a surge of LH. And you can see how the red line that represents the luteinizing hormone will surge, will have a sharp rise, will spike. The LH surge will actually trigger the next stage, which is in fact the ovulation. So again, those high levels of estrogen will create a stimulation in the LH that will surge, and as a result of this surge, the ovulation will occur. The ovulation represents the release of the ovum. Once the wall of the mature follicle and the ovarian tissue will rupture, will release the ovum inside the peritoneum cavity, and the currents of the peritoneal fluid that are created by the fimbria will capture it and will start propelling it through the fallopian tubes. There will be some women that are able to feel a slight abdominal pain that can persist between minutes and hours at the moment of the rupture of the follicle. In an average 28-day cycle, the ovulation usually occurs in day 14, kind of mid-cycle, and will be followed by 2 weeks later by the start of a new menstrual cycle. However, the only time that is very well known in terms of length, despite the fact that the whole menstrual cycle can have anywhere between 22 and 45 days, we know for sure that the last phase, the secretory phase, is 14 days and 14 days only. So this pre-ovulatory phase can have a length between 7 days to 21 days, depending on the variation on the length of the cycle. We are moving now into the post-ovulatory phase. And the LH, immediately after it produces the ovulation, will transform the ruptured follicle into a solid mass that now will be called corpus luteum because it has a yellowish color. And this structure will continue to produce estrogen as well as progesterone, a hormone that will promote and maintain the survival of a fertilized ovum that will become an embryo and later will develop into a fetus. So you can see that in the post-ovulatory phase, you can see that the estrogen is still kind of high However, the progesterone is really high now. Progesterone was very low before, and now it's very, very high. Under the influence mainly of the progesterone, but also the estrogen, the endometrium will continue to thicken, and the glands and the blood vessels will increase in size, making it very well prepared to receive a pregnancy if that would happen. And this phase is called the secretory phase, because the glands now will start to secrete increased amounts of fluids and nutrients. During the post-ovulatory phase, the ovum will continue to make its journey through the fallopian tubes towards the uterus, and if it's fertilized, the ovum will start beginning to secrete hormones that will go back, and by feedback, but right now, in terms of a positive feedback, will stimulate the corpus luteum to continue to produce hormones until the placenta is well developed. However, if the ovum is not fertilized, and usually it will die in a matter of 2 to 3 days, corpus luteum will slowly start to degenerate, and by about 11 days after the ovulation, will be completely gone. And as a result of that, there will be no progesterone or estrogen left, because the corpus luteum is involuting. So, just to summarize again, if the ovum is not fertilized, the corpus luteum will degenerate, and the levels of estrogen and progesterone will decrease. Without those hormones, the endometrium will not going to be supported anymore and will quickly degenerate as well. And as a result of that, will start small hemorrhages will appear in the tissue, and menstrual flow will show up, producing that bloody discharge. In the bloody discharge, there will be bits of endometrium breakage, so tiny parts of the tissue will be eliminated. Usually, the menstruation is in between 2 and 6 days. Even before the menstrual flow will cease, the endometrium actually begins to repair itself from underneath, growing new cells that are able to divide and recreate a new layer. The activities of ovarian hormones have a negative feedback, and they can be replaced by contraceptive therapy, or what we call birth control. The estrogen and progesterone in the birth control pills will inhibit actually the release of FSH and LH from the pituitary gland, and as a result of that, the ovary will not going to be stimulated. So the menstrual period that follows the withdrawal from any type of estrogen and progesterone most of the time will be anovulatory cycles. Menopause represents the time period during which the menstruation will cease altogether, and it usually occurs gradually between the age of 45 and 55, and is normally due to a normal decline in the ovarian function. Most of the ovaries will become scar tissue that will now no longer be able to produce and mature any follicles, and also will not, as a result of that, will not going to be able to produce the estrogen and progesterone. As a result of a decrease in the levels of the sexual hormones, the uterus and uterine tubes and vagina and vulva will become atrophic gradually, will vaginal mucosa becoming thinner and thinner, drier, and less sensitive. So menopause is considered an entirely normal condition. However, temporarily can be disturbing in some of the individuals due to a decrease in the estrogen levels that can produce nervous symptoms such as anxiety and insomnia, and sometimes hot flashes. How can we treat menopause? Well, the physicians may prescribe hormone replacement therapy to relieve the discomfort associated with menopause, as well with providing some protection, because the estrogens are promoting the deposit of calcium in our bones. So patients that are at menopause have an increased risk for osteoporosis, and as a result of that, a high incidence of pathologic fractures. So hormone replacement therapy can protect them from that. On the other hand, hormone replacement therapy may have additional risks as an increased risk for breast cancer, uh, risk of thrombosis and embolism as pulmonary embolism, especially in those patients that are heavy smokers. Also, women that have a history or a family history of breast cancer or circulatory problems may not be good candidates for this type of therapy because of the complications that they may bring. We're going to discuss now some disorders of the female reproductive system. And we'll start by discussing menstrual disorders. We call the absence of the menses as amenorrhea, meaning amenorrhea, meaning without any type of menses. It can be the result of insufficient hormone secretions or can be a result of a congenital abnormality of the reproductive system. It can be associated with high levels of stress or any psychological factors that may impair the menstrual cycle, and as a result of that will be part of the cessation of the menstrual flow. For example, in those individuals that are professional athletes and they are training themselves intensely, the menstrual flow may stop as a result of that. Very low body weight with a very low percentage of body fat is also associated with amenorrhea because of a reduced estrogen synthesis. Um, it's also seen in women that are starving or those that have eating disorders based on the same type of mechanism. Dysmenorrhea is a painful or a difficult menstruation. The primary one um, that has no known cause and usually will, the symptoms are becoming better and better until they disappear with aging or immediately after having one child. It One theory behind it is that prostaglandins are involved in uterine contractions and they may cause pain. And that's why some prostaglandin inhibitors can be used in treatment of this condition. Usually, just applying heat over the abdomen may relieve the pain and decrease the muscular cramps. The secondary dysmenorrhea is a result of what is called an underlying condition. So when I say that a condition is primary, it's related to that organ, and it's a dysfunction of that organ specifically, where a secondary condition is related to um, another issue. The secondary dysmenorrhea results from endometriosis or uterine fibroids. Um, the treatment usually is the treatment of those conditions. We have what is called abnormal uterine bleeding, and that can be an excessive menstrual flow as menorrhagia, or too frequent menstruation and intermenstrual bleeding, which is called metrorrhagia. Any of those may lead to anemia and may ask for intense and very specific medical attention. We are looking now into endometriosis, and endometriosis represents a growth of endometrial tissue anywhere else that is outside the uterus. Will commonly be seen on the ovaries, on the uterine tubes, peritoneum, or other pelvic organs. And the endometriosis will produce inflammation and other complications. The treatment is usually surgical. Um, and the main symptoms are the result of the fact that this abnormally situated endometrial tissue, that one of the theory is that it's a backflow of the uterine menstruation of the cells through the uterine, through the fallopian tube inside the abdominal cavity. This tissue that is implanted is in abnormal location will go through the same hormonal changes as the normally situated uterine tissue, and it will increase inside and it will bleed with every menstrual cycle, and this is why it's so debilitating and will lower the quality of life of that woman. Usually, the surgical treatment is necessary, and sometimes the endometriosis is the main cause of female infertility because of the scarring and the changes in the shape of the reproductive system. Premenstrual syndrome is a condition that will have physical and emotional symptoms that occur 1 to 2 weeks before the menstrual period. Most of those symptoms will include fluid retention as bloating and tender breasts, headache, fatigue, irritability, anxiety, and depression. In order to diagnose that, we'll ask our patients to just keep a just write down on a calendar and have a diary of their symptoms. And if they come with the same cyclicity as opposed to when the menstrual cycle starts, that will easily make the diagnosis. In order to treat that, a healthful and balanced and low salt diet will reduce the symptoms, along with reducing the tea and coffee or carbonated drinks. Tumors. We have both benign and malignant tumors of the female reproductive system. A fibroid usually is a benign tumor. It starts in the smooth muscle. It's called the leiomyoma. And in some studies, we found out that about half of the women that will get to age 50 will have one or more of those tumors in their uterine wall. Most of them, again, they are benign and will produce no symptoms. They can start being produced at puberty and will stop growing and will reduce their size at menopause or in women that are over age 50. In some cases, especially if they develop at very young ages, they may, and depending on the position of where they are placed, if they are developing inside the uterus or outside in towards the abdominal cavity, they may interfere with the development of a pregnancy and may be the cause for recurrent miscarriages. While they are growing, they may become larger and they can put pressure on adjacent structures, and they may cause symptoms because of that. Sometimes when they are very big, they may cause bleeding, and the treatment can be, depending on the size and the symptoms, may range from hormone therapy to suppress their development to surgery that can be limited to the removal of the fibroids and up to the removal of the entire uterus if they are many of them or if they are extremely big. Endometrial cancer, obviously, it's a malignant condition. It's the cancer of the endometrium. Usually will show up in women during or after menopause, especially in those that were exposed to high levels of estrogen. Those that have received estrogen therapy as just estrogen without the progesterone. There are some types of hormonal replacement therapy that they have only estrogen and will not going to be balanced with progesterone also. It's more common in female that had a few or no pregnancies and those that are obese. In terms of symptoms, they will complain of abnormal discharge or irregular bleeding. And a little bit later, they may complain of cramping and pelvic pain. The diagnosis is easy. It can be done by endometrial biopsy, and the treatment is surgery and radiation. If it's done as an aggressive and early treatment, the results are very good with high survival rates. Ovarian cancer, on the other hand, is the second most common reproductive tract cancer in women, and it's seen most common between ages of 40 and 65, and it's the leading cause of death in cancer in women. Most ovarian cysts that will develop they are non-malignant. However, some of them may become malignant, and when they do that, they have a tendency to progress very rapidly, and they are very difficult to detect because the symptoms are vague and they develop in a place in our body where there is a lot of space. So until they do not become very big and they do not put pressure on other organs, where they do not generate other symptoms, they will not going to alert the patient that something is wrong. Cervical cancer is directly connected to infections with human papillomavirus, with HPV, that normally will cause genital warts, and it's spread through sexual contact. So it's considered a sexually transmitted disease. the risk factor associated with cervical cancer will be early age of sexual activity, anything that will increase the exposure to HPV as multiple sex partners or unhealthy sexual activities. There is a vaccine that we are using now that is recommended for females before they start their sexual life, usually between age of 10 and 12. It's recommended also for the males because males, despite the fact that the HPV is not so aggressive in males, they can still transmit the condition. The early detection is through a pap smear. So here you can see how a pap smear is performed. The decline in the rate of advanced cases and the decline in the death rate from cervical cancer is related to the ability nowadays to identify very early through a pap smear the patients at risk and also to diagnose the condition in very early stages so the surgical treatment can be applied. Infections, STDs or STIs, the same ones that we describe for men may occur in women as well. Sometimes in women, some of them may have symptoms that are less obvious than um, in men than in women. Um, the infection in women, because of the way that the reproductive system is connected and interconnected, the different parts, they can spread more easily through the urinary and reproductive system, and they may result in abdominal complications as kidney infections and infertility quicker. Because if you really look into that, you can understand that through the vagina and the uterus, the fallopian tube are fully open inside the abdominal cavity. So in female, at any given moment, the abdominal cavity is fully open to the outside. Again, the most common STIs in female, just like in male, are chlamydia, gonorrhea, HIV, and herpes, the genital herpes. Syphilis is also encountered in female at the same high rates as in male, and when it's a condition that can be passed through the placenta from the mother to the fetus, and when that happens, it may cause either stillbirth or birth of an infant with a lot of not necessarily genetic congenital conditions. Genital warts caused by HPV is also increasing lately, and again they are connected to the cancer of the especially the uterine cancer. There is a condition that is called salpingitis, and that means an infection of the tubes. It's very common in infections with gonococci, especially and infections with chlamydia. Salpingitis, once healed, the healing produces a scar at the level of the fallopian tubes that may lead to infertility by obstructing the tubes and preventing the passage of ova. The pelvic inflammatory disease is an extension of an infection from the reproductive organ inside the pelvic cavity that will involve the peritoneum that can be localized in the pelvic area or it can expand to the whole abdominal cavity. The most common ones will be gonococcus and chlamydia that will produce this type of ascending type of infection. Again, they will be related with an increased risk for infertility. Discuss now contraceptive methods, and you have here a summary of them. And you can see that we have surgical methods, we have hormonal methods that are all of them will refer to the female, and we have barrier methods that they are both male and female. In addition to that, we'll have the others that refer to both of partners. Um, you can see that I will start by describing the surgical one really quick, and we'll walk through all of them. If you see here, we have two surgical methods, one for each of the partners. We have tubal ligation that can be done in females, and we have vasectomy that is done in male. During this procedure, the tubes are tied off, are disconnected, are cut, severed, or cauterized in order to prevent the delivery of the gametes. It will be at the level of the fallopian tubes in female and the level the ductus deferens in men. So a man that goes through a vasectomy will still have the ability to produce the hormones and the semen, as well as the ability to engage in the sexual intercourse. However, there will be no fertilization because the semen will not contain spermatozoa. The vas deferens that delivers just the spermatozoa will be disconnected. Birth control in most cases is achieved through what is called contraception, which is an artificial method of preventing fertilization of the ovum. However, there are other methods that are more accurately called abortifacient, where is an agent that will cause an abortion, that not only that they are preventing or they are trying to prevent to produce the contraception by preventing fertilization, but they also can prevent the product of conception if fertilized from implanting and developing into a fetus. And when we are looking into that, you see that um, to produce contraception by tying the tubes or by doing a vasectomy, this is a pure contraceptive type of method because we are preventing fertilization. There will be some other methods that they are a combination of both. They will prevent both the fertilization and the implantation. So when we are looking at the condoms, this is a pure physical barrier that will prevent the contact between the sperm and the ovum. Um, we have both male and female condoms. Um, the female one is a sheath that will fit inside the vagina, and the male ones are those that will be applied on the penis. They also have an added benefit, and this is because they protect against sexually transmitted diseases because the female and male parts, they will not going to come in contact because there is a barrier between them. Another type of contraceptive method is the hormonal one that will take advantage of this type of negative feedback loop. While the production of the hormones in the ovary is under the control of the gonadotropin releasing hormones, and as a result of that, the FSH and LH, if we are providing the body with constant level from the outside of estrogen and progesterone, that will trick both the hypothalamus, the pituitary gland, and the ovary into stop producing any of the hormones that will be part of this loop. So in fact, by doing that, we are putting the ovaries completely at rest. So the hormones can be delivered by oral pills, as a skin patch, a vaginal ring, and they can be stopped for 1 week every month, or they can be stopped every 3 months. There are other methods that will include injections every 3 months, or they may use implants of hormone-releasing rods under the skin. There are a whole range of options for delivering those. They will have different concentrations and different combinations of estrogen and progesterone. So far, the male contraceptive pill, there are some researches on this area. However, there is none on the market yet. In the male version, this pill will also inhibit the release of FSH and LH that are important in spermatogenesis. However, the use of testosterone as a negative feedback messenger requires regular injections and has quite a few side effects for the doses that are needed for this. There is another drug that is called mifepristone RU486, and this is used for termination of a pregnancy, in early termination of an early pregnancy if the conception had occurred. This drug will block the action of progesterone and will cause the uterus to shed its lining, and will, by doing that, will also shed the fertilized egg. It's usually used in a combination with prostaglandins that will help the contraction and expelling of the uterine tissue. In addition to that, we have another option that is called an intrauterine contraceptive. That is a small T-shaped structure, usually plastic, is very flexible, that will be inserted inside the uterus and will prevent um, the um, lodging of the fertilized egg on the mucosa. Uh, some of them will also deliver small quantities of hormones that they will also prevent the release of will prevent the ovulation. We'll discuss now issues related to infertility. And infertility is defined as the inability of a couple to achieve pregnancy after having regular and unprotected sexual intercourse for at least 1 year. And whenever we are analyzing an infertility case in a couple, we examine both the male and the female, and about a third will be related to the male, a third will be related to the female, and a third of the cases will actually have both partners having issues. Whenever we have a case of couple infertility, we are always looking first at the male partner. Because the procedures that are related to the fertility in males are simpler and less costly than those in females. So we are looking into the number of sperm that are required to um, degrade in order to um, produce a fertilized ovum. So we are looking into the fact that the male may have a low sperm count, which is called oligospermia. Um, and this can be a result um, um, of a testicle that can be damaged by x-rays or infections or toxins, malnutrition. All those are resulting in decreased sperm production. In addition to that, smoking or alcohol abuse, and sometimes excessive environment heat, just as in the case of someone that is regularly using a hot tub, can reduce the sperm count. Other causes for male infertility are not related to the number of sperms, but to their mobility, or to the fact that there is a blockage within the duct system that will not allow the flow of sperm. In some other cases, one may find out that there is a testosterone deficiency, or in some other cases will be drug abuse. In women, it's a little bit more difficult to examine and to collect the data. So, in order to define the ability of the sperm to, or the efficiency of the sperm, we are looking into their motility, and we count the number. Now, if we find out that the male is not the cause for the couple's infertility, we will look into other causes at the level of the female partner, and we will try and exclude infections, any kind of endocrine disorders, or abnormalities in the structure or the function of the reproductive system. We'll then look into solving and treating any types of STDs. We can try and diagnose if there is a blockage for the ovum transit from the fallopian tubes to the uterus, or any kind of blockage that will not allow the sperm to access the ovum at the level of the cervix, let's say. We'll also try to exclude endometriosis or early menopause or any cases of malnutrition.